Hello, everyone. Welcome to the CUGH online session. Our session titled as Prioritizing Mental Health and Behavioral Studies in HIV/AIDS Response Among LGBTQ Populations. So mental health issues occur at a high rate among LGBTQ populations, despite the associations between mental health conditions and high risk for HIV infections. Reduced medicine adherence and increased disabilities and mortality in this population. Mental health and behavioral studies are often neglected in clinical practice. So this session provides a unique opportunities to share state-of-the-art research and practice experiences from scholars and key stakeholders in the global. So it is my honor to introduce our first presenter, Dr. Seward Harrison, to give her talk. I would like to briefly introduce Dr. Seward Harrison. So she is a health psychologist with expertise in psychosocial and behavioral aspects of HIV, as well as the development and evaluation of health and mental health interventions for HIV-affected youth. She acquired clinical experiences through 6 years of practice in medical and community settings. This including extensive clinical work with vulnerable communities, including individuals from sexual, gender, racial, and ethnic minority groups. These experiences yielded first-hand knowledge on the impacts of stigma on health and mental health. Dr. Harrison then completed a postdoctoral fellowship at the University of South Carolina on resilience-based interventions for children affected by parental HIV. Now, as an associate professor of psychology at USC, her research examines how to improve clinical outcomes for individuals at risk for or living with HIV in the Southern United States. She is PI of a 5-year NIH grant from the NIMH that seeks to improve HIV care engagement and adherence to ART for youth living with HIV through mobile health interventions. She has also received intramural and extramural grants to fund studies on topics including health-related aspects of community resilience, HIV knowledge, awareness, and risk behaviors, HIV-related stigma, and predictors of HIV care continuum success. So let's welcome Dr. Seward Harrison. And because of the time conflicts, Dr. Seward Harrison is not able to stay to the whole panel, so I encourage you to ask her questions at her session. And to save our time, I encourage you to hold your questions after her presentations, but feel free to post your questions on the chat board at any time. Thank you very much. Go ahead.
Great. Thank you so much for that wonderful introduction, Dr. Chow. So again, great to be with you this morning. Well, this morning in the United States, at least. I see we have people joining from all around the world. Again, my name's Dr. Seward Harrison, and I'm from the psychology department at the University of South Carolina. I use she, her pronouns, and this morning I'm going to be talking about the impacts of mental health and substance use on PrEP uptake among lesbian, gay, bisexual, transgender, and queer individuals in the US. And I'm really excited to kick things off and share with you a little bit about what the HIV epidemic currently looks like in the US, the disproportionate impacts on our LGBT community, and really focus in on how we need to scale up PrEP by addressing some of these mental health and behavioral health challenges. So just some disclosures as I get started. I do receive research funding from NIH, CDC, and ViiV Healthcare. Okay, before we launch into our session this morning, I just wanted to say a few words about words. So words and word choice are really important when we're working in this space with people whose identities are marginalized and minoritized. So words both cause and also reflect stigma that is held in our societies and by us as individuals. And I wanted to affirm that I support the use of person-first language and make an effort to follow the UN/AIDS guidelines on HIV terminology. When I'm talking about others' research, I will generally use the terms and the identity terms that are used by that original research team. So I just wanted to make that clear. And also to share, if you're a researcher or a community partner working in the HIV and LGBT sphere, then I'd really encourage you to look up the UN/AIDS terminology guidelines. I found them to be really helpful for thinking about how we can destigmatize our own language in this field. Okay, so we've already had an introduction, but again, I'm a health psychologist. I run the Healthy Futures Lab at USC. Please check out our research. And I really focus on social and behavioral aspects of HIV and other infectious diseases. In today's talk, I want you to gain an appreciation of the role that social and behavioral science needs to play in us continuing to make progress addressing ending the HIV epidemic. We're going to focus in on PrEP and talk about how mental health and substance use disorders can get in the way of us scaling up PrEP, especially among LGBT communities. All right, so since 2016, I've been working in South Carolina, really engaged in a lot of community-based HIV research, working closely with state partners and community organizations. As part of that, I do a lot of advocacy work, going along with community partners to talk to our state legislators about HIV and why it's so important for us to continue to provide funding for HIV. And often what these legislators will tell us is, they'll be really surprised. They say, are we really still talking about HIV? Is this really still an issue here in the United States? So what I tell them is, yes, it's a huge issue, but very much disproportionately impacting some areas and some communities more than others. Here you see a map of the US, and I'm located in South Carolina. Let's see if I have I thought maybe I would have a little circle pop up, but you see on the bottom right corner, in South Carolina, 1 in 86 residents is estimated to have a lifetime risk of acquiring HIV, 1 in 86. So that's a very high rate. And we can compare that to other areas of the United States where the HIV rate is very low, such as in that northern area, states like Montana, North Dakota, South Dakota, where you see it's 1 in 400 to 1 in 500 or 1 in 600. So across this area of the Deep South, that's in that dark blue, we see really high rates of HIV, and these are primarily driven by structural challenges in this region. Here in the US, we continue to have around between 36,000 to 40,000 new HIV diagnoses occurring every year. And we have over 1.1 million people in the US living with HIV, a large number of those who are undiagnosed. So while new infections has remained steady for many years, even with our great new tools like PrEP, which we're going to talk about, we haven't been able to really lower that number of new infections. So we're not doing a very good job here in the US on HIV prevention. And what we see is that some groups are really impacted. So here in the US, our HIV epidemic is, it's driven primarily by male-to-male sexual contact, with Black and African-American men and Hispanic or Latino men being at the highest risk for HIV, followed by white men who have sex with other men, and then followed by Black and African-American women who acquire HIV through heterosexual contact. So we have these real deeply seated disparities by sexual identity and by race and ethnicity. And I always share this stat: if current rates persist, 1 in 2 Black men who have sex with men and 1 in 4 Latino men who have sex with men in the US will be diagnosed with HIV during their lifetime. So to me, this is a real human rights issue that we are allowing a very particular community to be so impacted by a preventable health condition. All right, so in the US, we have a new federal initiative called the Ending the HIV Epidemic, which is a plan to help us really ramp up our progress in preventing new HIV infections and getting all people living with HIV into effective care. So we're already realizing we're not on track to meet these goals that we've set. So we're falling behind even as we're just getting started. But the EHE plan aims for a 90% reduction in new HIV infections over the next decade. And this really focuses on 4 key areas to help us get this epidemic under control: diagnosing all people as soon as possible, treating people rapidly and effectively with ART, antiretroviral therapy, to help them reach and maintain viral suppression, preventing new transmissions by proven interventions like pre-exposure prophylaxis or PrEP and syringe service programs or SSPs, and then really using our data to respond quickly when we see clusters, when we see new outbreaks happening in different communities. More than half of all new HIV diagnoses in the US occur in just 48 counties, as well as these 7 states with a high rural burden of HIV. So geography really, really matters, and our community networks, our social and our sexual networks really matter as we think about what this epidemic looks like. And again, here we see these 4 pillars. Today, I'm going to focus in on prevention. So we've got a lot of really effective tools in our tool belt now in 2023 to prevent HIV. And PrEP is probably our most powerful one, right? So many of you are probably familiar that since 2012, we have a once-a-day pill available that greatly lowers an individual's risk of acquiring HIV by around 99% risk reduction against acquiring HIV if taken daily, and a good amount of risk reduction for transmission through injection drug use as well, though not quite as high as preventing sexual transmission. So when we think about who's a good candidate for PrEP, and again, this might be background information for many of you, but just want to point out that lots of people are good candidates for PrEP. People who are having condomless sex with partners who you don't know their HIV status, people who are having multiple or anonymous sex partners, having riskier sexual behavior such as sex at parties, engaging in transactional sex or sex work. In other words, needing to trade sex for security, for a place to live, for money, for food. And even more broadly, people who've been diagnosed with at least one bacterial sexually transmitted infection in the last year. I'm a professor on a college campus, and that means that many, many of our university students are good candidates for PrEP and should be talking to their provider. PrEP has some other really important uses, such as trying to conceive with the partner who has HIV, and for women who are at ongoing HIV risk. So we'll share these slides happily, but there's some excellent clinical guideline tools that are available that can provide information for providers about how to talk to patients about PrEP, who's a good candidate, and how to make decisions about what type of PrEP to prescribe. We now have exciting news that we also have long-acting injectables for PrEP in the form of cabotegravir, which is approved for cisgender and transgender men and women with no limitations based on the type of sex that they're having. And this ultimately transitions to every 2 months injection to provide that HIV prevention in a way that for many people may be easier than having to remember to take that pill every day. So because we got started a few minutes late, I'm gonna skip through a few of these slides, but just want to share that we've got these great tools, but we're not doing a great job getting them out to the communities that need them. And especially when we look at our highest risk groups, so men who have sex with other men. Currently in the US, men who have sex with other men are reporting low use of PrEP, reporting concerns about it, many reporting they haven't heard about it. And oftentimes what we hear from individuals is that their providers aren't bringing up PrEP, that it's on them, it's on that patient to bring up and initiate a conversation when they go in to see that healthcare provider. So, as a health psychologist, I really think context is the key. And especially as we're thinking about such a stigmatized health condition that we know is driven by institutional and systemic inequities, we really need to use intersectional and socio-ecological frameworks to help us understand, why we're not making the progress that we want to make in terms of HIV prevention, especially among our sexual and gender minority communities here in the US. So we know that mental health and HIV have a bi-directional relationship. And today I'm going to focus in primarily in talking about major depressive disorder and anxiety disorders. But we know that poor mental health both can increase behavioral risk factors for acquiring HIV. And also when someone has HIV, because of that stigma that's associated with it, that also raises the risk for experiencing mental health concerns like depression and anxiety. I'm listing here some of those major symptoms of depression and anxiety disorders that we're going to talk about. So when we think about major depressive disorder, we're thinking about more than just feeling a little sad, real depressed mood, losing interest in the things that you used to enjoy, major changes in appetite and sleep, feeling very fatigued, not having any energy, and that this begins to really impact a person's ability to fulfill their roles in their family, at their workplace, at their school. When we think about anxiety disorders, very common in the United States, these are fears or worries in a situation where that fear or worry is not necessary, is not helpful, that last for 6 or more months. And are out of proportion with that situation and clinically distressing and impairing to that individual. So individuals who are having difficulty controlling their worries, feeling always on edge, always tense, beginning to avoid people, places, or things because they cause those feelings of anxiety. When we look at both major depressive disorder and anxiety disorder, specifically general anxiety disorder or GAD, we see that gay and bisexual men and transgender women have much higher risk for having these mental health disorders than the general US population. And it's really important for us to understand that this is not because of failures on the individual part. This is because these individuals are navigating a sociocultural context that is highly stigmatizing, highly discriminating, right? Where often identities have to be concealed for safety and for protection, right? So we see these real impacts on mental health because of the way that our society often treats individuals from sexual and gender minority groups. Also want to just touch briefly on substance use disorder. So substance use disorder is a diagnosable condition where individuals are having impaired control over their substance use. So they're spending larger and larger amounts of their time and longer time periods than intended using a substance and recovering from that substance use. Attempts to cut down, but they're not successful. Cravings for that substance. And again, these now start to begin to cause impairment in that person's social world. In addition, substance use disorder is characterized by risky use. So a person may continue to use a substance even though it's hazardous to their health or their mental health. They may have to go into risky environments in order to get that substance and use that substance. And then finally, with substance use disorder, our fourth main criteria is looking at pharmacological criteria. So we know substance use disorder really results from a rewiring of the brain's pathways involving reward and motivation. And we see heightened tolerance for a substance. We see withdrawal symptoms when that person cannot access that substance. So again, these physiological symptoms. So when we look at substance use disorder prevalence in the US, we see the same pattern that individuals who are lesbian, gay, or bisexual are at more than a doubling of risk compared to the general US population. And we also see that around 13% of lesbian, gay, and bisexual adults in the US have co-occurring substance use disorder and mental health disorder. So often these go hand in hand. All right, so what factors could contribute to some of these mental health disparities? you all could put some answers in the chat if you can think of some of the drivers behind why do we see LGBT communities, having such higher rates of depression, of anxiety, of substance use disorder. And I'm not able to share the chat, but Dr. Chow, if you want to call out some of the answers, if anyone's posting any answers. Stigma. Okay, great. Actually, I can see the chat. Stigma and discrimination. Absolutely. Socioeconomic factors. Great response from Justin. Yes. And we see, because, for instance, individuals from sexual and gender minority groups face additional challenges in their educational settings, in their workplace settings. Many youth in the United States who are queer, who are from LGBT communities, are often pushed out of their home, right? Have a much higher risk of becoming homeless and then entering into poverty. And then that creates these very harmful cycles with substance use, with mental health. Excellent. All right, so I wanted to share about a recent paper I published with my grad students and with another HIV care provider that looks at how mental health, including depression and anxiety, impact PrEP care with a specific focus on LGBT communities. So as we're thinking about PrEP, we have to think about people need to be aware of PrEP. They need to have opportunities to be prescribed PrEP and start taking it, uptake. And then they need to be supported in adhering to PrEP and staying on it when it's useful for them, right? That retention and care. So we can think about this as the PrEP care continuum. So if you want to find this paper, it's in the International Journal of Environmental Research and Public Health, and it's freely available, a scoping review investigating relationships between depression, anxiety, and the PrEP care continuum in the US. So I'm going to just very quickly breeze through some of our major findings. What we found was thinking about the impacts of depression on the PrEP care continuum, the majority of studies have found no effect of depressive symptoms on PrEP awareness, interest, or willingness to use, right? So even if someone is meeting criteria for depression, we don't see that that's impacting their interest or their willingness to use PrEP, including in studies published on men who have sex with men in the US, as well as female sex workers and other vulnerable groups. No studies have found a relationship between depressive symptoms and PrEP initiation. And when we compare depressive symptoms between PrEP users and non-users, there are some mixed findings. Very limited research in this area. This is a really important area for those of you who do research who are on this talk to think about looking at. It's important for us to begin to dig deeper into this relationship between depression and PrEP. When we look at adherence and retention, again, we have a few studies that have been published and are in the peer-reviewed literature, and those really show mixed results right now. Among studies in the US, most have found that depressive symptoms are unrelated to adherence and unrelated to decisions about whether somebody chooses to discontinue PrEP. A smaller number of studies have found that depression is associated with poor adherence. And interestingly, all qualitative studies that used interviews or focus groups to talk with PrEP users, we heard from PrEP users in those studies that depression is perceived as a barrier to adherence, right? So individuals who are feeling sad, who are feeling low energy, perceive that that might be a challenge to adherence. But right now, I'd say overall, the literature is kind of mixed on whether that's actually bearing out. So we really need more studies to better understand the relationship between depression and PrEP. One important large-scale study, the IPREX study, a 72-week longitudinal trial, showed different patterns of depression among men who have sex with men and trans women on PrEP. So for men who have sex with men, moderately depressed, men had slightly better adherence, actually, than those who were not depressed at all. And for trans women, however, this protective effect was not found. So again, mixed findings right now when we're thinking about particular communities. The bottom line, though, is really important to share that depressive symptoms are not a contraindication for PrEP. So as providers are deciding who's a good candidate for PrEP, It's okay if that individual is mildly depressed or even severely depressed. We don't see that as a contraindication for PrEP, but we want to really be thinking about treating those depression symptoms so that individuals can have higher quality of life while they're also preventing HIV through their PrEP use. Okay, now as we think about anxiety, 2 studies to date have found no association between anxiety symptoms and PrEP awareness, interest, or willingness to use. And anxiety has not been found to be associated with PrEP appointment acceptance or with self-reported PrEP use. However, one recent study did show that anxiety is related to self-efficacy. So in other words, people who have lots and lots of anxiety, they question their own ability to adhere to this new regimen of PrEP. So we want to make sure we're providing more support for those individuals so we can reduce anxiety because they may be feeling like they don't have the skills, they don't have the tools to adhere to this new part of their daily regimen. And research is very limited right now in terms of anxiety and PrEP adherence. And at least 2 studies have showed anxiety is not associated with PrEP discontinuation. All right, so moving into this final area of substance use and PrEP awareness, there was a great systematic review that just came out in 2021 that I would direct your attention to, looking at the PrEP care cascade in people who inject drugs. And remember that individuals from LGBT communities are at increased risk for substance use disorder. Overall, we found we've got a lot of work to do to scale up PrEP in the US among people who inject drugs. Awareness and knowledge remain really low. And we do see some gender disparities with men being less aware than women that PrEP is a useful tool that's out there. Substance use has been found to be associated with lower willingness to use PrEP. And qualitative interviews have shown that a lot of individuals who are engaging in injection drug use, they're really focused on their basic survival needs, right? Economic and housing insecurity, how they're going to deal with their symptoms of withdrawal, and that those are taking a lot of precedence over PrEP. And therefore, it makes sense that we still have low PrEP uptake. Now, interestingly, this review did show that men who have sex with men were the most likely among all drug users to initiate PrEP. So that message does seem to be reaching to some of our men who have sex with men who are also engaged in injection drug use, but we have a lot of work to do. We do find that substance use can really impair PrEP adherence. And this is not surprising. So individuals who are engaged in lots of harmful drinking, moderate and high levels of cocaine use are more likely to be non-adherent to PrEP. Stimulant use also predicts poor adherence, as well as club drug use. All right, so that makes sense. When people are high, it's tough to remember to take PrEP. When they're feeling crappy because they're dealing with hangovers or they're dealing with withdrawal symptoms, it's tough to remember that. And also, there's a lot of disruptions when people are returning to use and then coming back out of use. Again, disruptions to that routine. So overall, we really see some mixed findings here on that PrEP care cascade. All right, and then one thing I just want to leave you with is this idea that we also need research on the effects of PrEP on mental and behavioral health. So not just how mental and behavioral health conditions impact someone's willingness to use PrEP, but what does going on PrEP do potentially for someone's mental health? Does it make them feel less anxious about risks of acquiring HIV? Does it make them improve their mood a little bit? Some qualitative studies have shown that participants attribute PrEP use to reduced anxiety symptoms, and that PrEP is associated with the peace of mind, more feelings of being in control of your sexual behavior, your sexual activity, and actually can enhance feelings of sexual well-being. For instance, a longitudinal analysis of men who have sex with men from Whitfield and colleagues showed declines in sexual anxiety over time following PrEP initiation. So it's really exciting to see that PrEP may have these beneficial effects for gay men, bisexual men, and other men who have sex with men, including reducing feelings of internalized homophobia, lowering anxiety, lowering depression. All right. So just wrapping up with a few care considerations, PrEP may reduce some of these negative effects of depression on risky sexual behaviors. We've got mixed findings right now on that role of depression on PrEP adherence. PrEP may reduce anxiety by reducing some HIV-related stressors. And we know that PrEP self-efficacy, however, is lower among those who are anxious. So really important to be assessing for symptoms both of depression as well as of anxiety when starting individuals on PrEP. And then, harmful substance use really needs to be monitored, because if someone's on PrEP and using lots of substances, we know that's linked with non-adherence, and adherence interventions and treatment referrals for substance use disorder are really needed. So there are a few PrEP adherence interventions that have been developed. So I direct your attention to the Life Steps program by Taylor and colleagues, and just really wrap this up by saying we need so much more integrated behavioral health as we're thinking about PrEP for our sexual and gender minority communities. We know there's high occurrence of both mental health and substance use disorders within these communities. If we can get into our sites that are prescribing PrEP and put screening for mental health disorders and for substance use disorder there, and deliver treatment there in the same setting where PrEP is being prescribed, that gives our best chance at both preventing HIV as well as improving, again, the quality of life. And there's lots of quick, easy, and free screeners that are available to help get that integrated care in there. And again, would just make a plug for, as we're thinking about reducing new HIV or preventing new HIV cases, as we're thinking about ending the HIV epidemic in the US, it's just critical that we use these intersectional frameworks and really explore, right, the systemic and structural issues that are impacting the lives of individuals from sexual and gender minority groups. So appreciate your attention. I know we started a few minutes late, so maybe you have time for 1 or 2 questions, and then we'll move on to the next talk.
Thank you so much. Dr. Seward Harrison gave such a wonderful presentation. She introduced the mixed findings based on the systematic review, and also identify the benefits of integrating the mental health and substance use disorder screening and treatment into the PrEP care for the LGBTQ individuals. We do have the question on the chat board. So the question is from Mr. Glenn Cole.
Yes, I think,
yeah.
I can see it. Thank you so much. So great question from Glenn. So is there an aspect of that adherence relating to whether the person is juggling multiple medications? Like if someone's taking SSRIs for their depression, or maybe if they're in a habit of taking even daily dietary supplements. I don't know the answer to that, but what a great question, right? You could imagine that if someone is already in the routine and very adherent to another medication, that perhaps it's easier to add PrEP into that daily routine. So that would make sense to me, but I don't know right now if there's research out there, but I would love to see it, or if others are aware, please do share. Thank you. And I think just to kind of follow up on that, I do think that it's really exciting in the US right now as we're thinking too about injectables. So for those individuals who do struggle to take their medications, and we know adherence is low, not just among HIV drugs, right, but among drugs in general. Most Americans who are prescribed a round of antibiotics do not finish it, right? So they don't adhere to the end. So, with cabotegravir and injectable PrEP, there's a lot of excitement right now around, will this really help people be more adherent? And especially people who are juggling concealed identities, who are very worried about someone seeing that PrEP pill box, in their medicine cabinet. Is this a way to discreetly, get PrEP to some communities that may struggle with the daily adherence, or may also just have real concerns about their identity being outed by that PrEP prescription bottle? So. And then a final question is, are there any data about people living with HIV who want to take PrEP but don't have access to it due to several factors in reaction to anxiety? That's a good question. I'm not familiar. We do know there's lots of barriers in the US to starting PrEP. including financial barriers. We have major problems with our healthcare providers not feeling comfortable, not being knowledgeable about PrEP, so they're not bringing it up in primary care. And really right now, I'd say the biggest challenge in the US around PrEP is who's going to own PrEP. Is it going to be our infectious disease providers? I would say it can't be them because they're primarily treating people who are already living with HIV. So we're really in this moment where we're trying to push PrEP over to our primary care providers, but there's some resistance and unwillingness. So, I appreciate this question just about, other barriers. I think both those come from individuals, like you say, anxiety, but they're also coming from other more systemic issues in our system. Thank you. Okay, so maybe we're ready to move over to our next talk.
Thank you very much, Seward.
Okay, great. Thank you so much. And again, please reach out if people have other questions or want to collaborate.
Wonderful. Oh, I see our facilitator, Dr. Banky Olatose is here. And Banky, I think our next presenter is ready here, Johnson Zixin Wang. So maybe you can go ahead to introduce him.
Absolutely.
Thank you very much.
Good morning, everyone. Good afternoon, wherever you are in the world. It's my pleasure to introduce Dr. Johnson Wang, who is an assistant professor at the Chinese University of Hong Kong. Dr. Wang obtained his Bachelor of Science of Medicine and Master of Medicine degrees from the School of Public Health, Peking University, and his Doctor of Philosophy and Public Health from the JC School of Public Health and Primary Care at the Chinese University of Hong Kong. He has been appointed as assistant professor in the JC School of Public Health and Primary Care since 2020. He's a member of the executive committee of the Center for Health Behaviors Research and the associate director of the Community Research Program on AIDS. He received the Early Career Award from the International Society of Behavioral Medicine in 2016. His research interest includes HIV prevention, application of artificial intelligence in health promotion, and implementation science research. So Dr. Wang, will hand over the floor to you. And just like we did with Dr. Harrison, we'll save questions for last. You can please put your questions in the chat box. Thank you.
Okay, thank you. Thank you for your introduction. So can everybody hear me? I guess yes.
Yes, we can.
Okay. So hello. So good morning to you. So it's evening in Hong Kong. So I'm Johnson from the School of Public Health. So it is my great pleasure to have this chance to share with you our project, which is a development and evaluation of a chatbot providing real-time counseling supporting HIV testing for men who have sex with men. Okay, so first of all, I have to thank for all my team members and the collaborative community-based organization, which is the AIDS Concern of Hong Kong, and also the funding sources. And thank you for the AIDS Trust Fund for supporting this project. So here's the outline of my presentation. So first of all, I will quickly go through the background of my project, and then I will spend more time explaining the details of the chatbot development as well as the randomized control trial, which used to evaluate the performance of the chatbot. And at the end, I will share with you some preliminary results because the project is still ongoing. So first of all, I think everybody knows the importance of HIV testing, so which is one of the recommended strategy for HIV prevention by the WHO. And as just mentioned by Dr. Harrison, the men who have sex with men are at the disproportionate burden of HIV. And the situation is similar in China and mainland China and Hong Kong. So in Hong Kong, this group of MS7 is also at very high risk of HIV infection. So and the HIV testing is recommended for men who have sex with men every 3 to 6 months. And the recommendation is the same in Hong Kong. And it is also very important because the high coverage of HIV testing is the first step to achieve the UNAIDS 95 targets. Okay, and the introduction of the HIV self-testing can remove the potential barriers of the facility-based testing, such as those involving inconvenience, stigma, and the concern of privacy. And the systematic review and meta-analysis showed that the HIV self-testing could significantly increase the uptake and the frequency of HIV testing. So as a result, in 2016, the WHO strongly recommended that the HIV self-testing should be offered as an additional approach to HIV testing service. So however, although the convenient, so they were concerned that the HIV self-testing users may skip the pre-test and post-test counseling, and therefore they are concerned related to incorrect procedures, which would lead to some invalid results. So previous studies showed that less than 1/4 of users can complete the test successfully without any errors. And also, if you have tried HIV self-testing before, you can see the instruction printed on the package of the HIV self-testing kit. Sometimes they are very confusing and very difficult to follow. And there are also a bigger concern is that inadequate for the users, support for the users, especially for those who were screened to be HIV positive. So usually if they did the self-testing without any counseling support, so they are getting kind of trouble if they got a positive result. So all this will lead to some issues related to the linkage to care. So as a meta-analysis indicated that the linkage to care of HIV self-testing was somewhat lower than the standard of care facility-based HIV testing. And the previous study also showed that the self-testers, they are consistently wish for the pre-test and post-test counseling to be available. And in 2014 and 2015, so our team developed an HIV self-testing service, so which we called it the home-based HIV self-testing with online real-time instruction and counseling. So the service is like that. So first of all, a free HIV self-testing kit was mailed to the users by mail. And then upon appointment, so trained HIV self-testing administrator will provide some online real-time instruction and standard of care pre-test and post-test counseling through some live chat applications. For example, like the Skype and WhatsApp and the Line. And we evaluate this service by using the randomized control trial as well as some implementation studies. And we find that it has the strength of it can significantly increase the HIV testing rate. And also it can reduce the sexual risk behavior. And the linkage to care for the HIV positive people is very good. So 100% of the HIV positive users were linked to HIV treatment and care. But however, we also find that there were some constraint of this service because it's kind of resource demanding. So for one episode of this service, it would take an hour to prepare and to implement. And sometimes the users, they want to do the self-testing at midnight. Okay, so it's kind of trouble, or during the weekends. So it creates a lot of burden on the HIV self-testing administrator. So therefore, we find it difficult to implement it at a larger scale. But luckily, so with the development of the new technology, we find that by using the chatbots, so it offers us a chance to provide this real-time counseling support for the HIV testing users with lower resources demand. Okay, so the chatbot, as we all know, is a computerized program that acts to replicate human interaction through text, speech, and other forms of communication. And nowadays, with the use of large language model and the machine learning, it can largely increase the accuracy of the human and the machine interactions. So the chatbot do have a lot of advantages because of this technology. It can offer some personalizing, engaging, and on-demand health promotion and information. And it can proactively interact with the users, which can also improve the compliance of the participants. And more importantly, it's fully automated and it requires less resources to implement or maintain. So it's potentially sustainable. So then this is the aim of our project. So the project there are two phases. So in the first phase, so we develop a fully automated AI chatbot to provide a real-time instruction and counseling for the HIV testing users. And the second phase, so we conduct a non-inferiority randomized control trial by comparing the HIV self-testing chatbot versus the human-delivered HIV self-testing service we developed before. Okay, so we compare these two services. So there are some specific objectives for the non-inferiority randomized control trial. So the primary objective is to establish whether the HIV self-testing chatbot will produce similar effect to the HIV self-testing. We call it HIV STOIC, which is the online real-time instruction and counseling provided by people. Okay, HIV STOIC. So in increasing the HIV self-testing uptake, as well as the proportion of the HIV self-testing user receiving counseling alongside the testing within a 6-month study period. And the secondary objective, we compare this HIV self-testing triple versus the OIC on the prevalence of condom-less anal intercourse, multiple sex partnership, and uptake of other type of HIV testing at month 6. So first is the development of our chatbot. So the development of our chatbot was informed by the in-depth interview of local MSM and those experienced HIV testing administrators. So using these interviews, we crowdsourced the common concerns and frequently asked questions related to HIV self-testing and HIV. And also, we prepared the response to address these common questions and concerns. And we also try to understand the potential users' expectation of the chatbot. And then we use the WhatsApp platform to implement the chatbot. That is because the WhatsApp is the most commonly used instant messaging apps in Hong Kong. So about 85% of the Hong Kong people do have access to the WhatsApp. So among young people, so most MSM are young. So for the young people, almost 100% of them have access to the WhatsApp. So you make a very suitable platform and a popular platform. And so this is the architecture of our chatbots. So the chatbot system was there was chatbot here, so which combined we include the chatbot function and the logic and the knowledge graph, which link the questions with the responses, and also is the storage of the intervention material. And there is also an administration system, which has 3 different modules, and the dialogue management modules, and the user management module, as well as the multimedia modules. So the dialogue management modules, they can record all the conversations between the users and the chatbots. So it can extract the information from the users' questions or their inputs, and it will be analyzed by the natural language processing function, the NLP functions. And then it will trigger the response in the knowledge graph, and then it will give them a appropriate response to that kind of their input and the questions. And for the user management modules, so the administrator will be able to review the progress of the delivery of the counseling, so we can see who have used it and whether they have complete the sections. And the multimedia multimedia management modules, you can support the image and the video uploading. So this is how it works. So usually the users, when they send out a message to the chatbot, so it will go through the WhatsApp server, and the WhatsApp server will forward the message to our chatbots. So, and the chatbot will process the message, and then they send out a response to the WhatsApp server, and the server will give it to the users. So the whole process will last less than 1 second. So usually the users will not feel any sluggish. So during the conversation. So after we developed the chatbot, so we conduct a pilot test. So we invite 30 MSM to use the chatbots, and we retrieve the conversation with the chatbot and review it to improve the human and machine interaction. So the pilot, the result is quite satisfactory. So all users feel like the chatbot is easy to use and very user friendly. So here's the workflow of the HIV self-testing chatbots. So the procedure is to simulate the standard of care pre-test and post-test counseling for the HIV testing and counseling. So this is for the pre-test counseling. So first, there is the risk assessment component. So the chatbot, it will ask the participants some standard questions to assess their risk. And something like that. So they will show a question on their screen, and the participant, it also show the response category. So the participant can press a button on the screen, so they make it very easy to answer the questions, or they can use a voice message, or they can enter the number representing the response category. So we allow multiple options for the entry to make it more user friendly. And these questions, they were related to the injective drug use and the condom use, as well as the PrEP use. So it's in line with those who were asked during the standard of care pre-test counseling. So the chatbot will then interpret their response to these questions and to define their risk levels. And then the chatbot will provide some health education advice tailored to their risk levels. So first of all, the chatbot will inform the user about the risk levels and explain why they are at such a risk. And for those who are at high risk, the chatbot will send out some message trying to preparing them for potential positive testing result. And for users without high risk, the chatbot will send the advice asking them to maintain their safe sex practice. And then the chatbot will try to ask to obtain the consent from the users for perform the HIV self-testing. So the chatbot will ask whether they're ready for it. And so at this, the user can raise their concerns related or questions. So they can either select their concerns from a list of frequently asked questions, or they can enter the question using free text. Okay, so the chatbot will identify the keywords and then provide some response with the closest match, and then you will confirm their consent. And then after having the consent, the chatbot will play a pre-recorded online demonstration video showing the procedures of using an oral food or blood-based HIV testing kit. So that depends on which kit the user have received. Okay, they can choose to watch it. And then the users they perform the testing, and they were asked to report their result by answering multiple choice questions. So the chatbot, they will show example of positive, negative, as well as invalid result in order to help the users to interpret the results. So moreover, so the chatbot will also invite the users to take a photo of their testing result and upload the photo to a secure web page. And the web page will be there will be an algorithm that will analyze the photo in order to confirm the testing result. So this is optional. So the uploading the photo is optional. And also the photo, after the system confirm their result, the photo will be deleted from the server. So in order to protect the privacy of the users. And then last but not the least is the post-test counseling. So if the users have a negative testing result, and the chatbot will explain the user is not infected unless the test was taken within the window period. So it's explain the concept of window period. And also they will remind them about the risk of HIV infection, and also provide some advice of safe sex practice and emphasize the need of regular testing. And for those with positive testing results, the chatbot will automatically notify designated support staff from the collaborative NGOs, so who will follow up with the users as soon as possible. So when the user's waiting for the staff contact to approach him, the chatbot will explain, well, actually, this is a preliminary positive test result, and you actually need a confirmatory test in the Department of Health. And it also informed the users that the staff from the collaborative NGOs is already notified, and he will follow up with them as soon as possible. And it also gives them information about the HIV treatment. So we emphasize it is very effective. And in order to provide some, so sometimes we're concerned about whether the user will have some mental health crisis after they have the positive result. We also provide a hotline number of the 24-hour emotional support and also the collaborative NGO. And we will also emphasize that our project staff can accompany them to visit the NGO or the Department of Health if necessary. Okay. So in order to meet the needs of different groups of users, so for the HIV, in both groups, so the users can have the options to receive comprehensive counseling support, so which contain the standard of care pre-test, counseling, the report and interpretation, the result, as well as the post-test counseling. And for those who are already very familiar with the procedures of the HIV self-testing, they may not need the instructions or the pre-test counseling for need assessment. So we offer them a simplified counseling support. So so after they report the result, so there will be an interpretation of their result, as well as we can offer the post-test counseling. And so regardless which type of counseling support they select, so all users, they were strongly recommended to report their testing result to either the staff or the chatbot. Okay, so in order to evaluate the HIV self-testing chatbot, so we conduct the already randomized control trial. So here's the inclusion and exclusion criteria of our participants. So we recruit Hong Kong Chinese-speaking men for age at least 18 years old. They have to have annual intercourse with at least one man in the past 6 months. And they have to be access to the WhatsApp, and they have no intention to leave Hong Kong within for 1 month consecutively within the study period. And those who self-reported as HIV positive, they were certainly excluded from the study. So here show the flowchart diagram of our studies. So we approach 617 MSM. So and 29 of them were not eligible, 60 of them refused to participate, and 528 were randomized into either the HIV self-testing chatbot group or the OIC group. So for the chatbot group, so first of all, they watch an online video promoting and introducing the HIV self-testing chatbot. And then they will send a free self-testing kit. So after they have the kit, so we will implement the HIV self-testing chatbot. So similarly, in the OIC group, so they will watch an online video introducing the HIV ST-OIC. And then they will also receive a self-testing kit for free. And then we will upon appointment, trained staff will implement the service. And all participants, they will follow up 6 months afterwards. So our primary outcome is the self-reported uptake of any self-testing at month 6. And also the proportion of HIV self-testing users who have received counseling support along with the HIV self-testing. So the chatbot will document the number of HIVs of the use. And the HIV testing administrator will also record the number of HIV STOIC performed by them. And the secondary outcome is as I mentioned in previous slides, is the condom-less anal intercourse, multiple sex partnership among the users, as well as the uptake of other type of HIV testing during the follow-up period. So here's the statistical analysis. We use intention to treat analysis. And I will share with you some preliminary result of our study. So here's the baseline characteristic of our participants. So majority of them were young, so age between 18 to 35 years old, currently single, received high educations, full-time employed, and identify themselves as gay. So the social demographic is similar to the overall MSM in Hong Kong. And regarding their sexual risk behaviors, we can see over 50% of them, they have condom-less anal intercourse with men in the last 6 months, and over 50% of them have the multiple male sex partnership. So the chemsex, which refer to the use of psychoactive substance before or during anal intercourse, is about 8.7%. So regarding the HIV testing service utilization in the past 6 months, so less than 50% of them have used any type of HIV testing. About 15% of them use HIV self-testing. And 14% of them were currently on PrEP. And there was no between group difference observed. And here's the between group difference in the primary outcomes. So the HIV self-testing uptake rate in the treatment group is slightly higher than the HIV STOIC group. So it's about 70% versus 65%. And the difference was not of statistically significant. And for the HIV self-testing users, so there was 100 of them. So in both groups, so all of them, they report their testing results, so either to the chatbot or to our staff. And the proportion of using simplified counseling is similar, it's about 58%. But as you can see, there is significantly more participants, or more users in the chatbot group. They receive the comprehensive counseling support. So it's about 40% versus 5%. So the difference was significant. And therefore, the overall proportion of the self-testing user who received counseling support was significantly higher in the HIV self-testing chatbot group. And I will also share with you about the handling of the suspected HIV positive cases in the HIV self-testing chatbot group. So there are 2 participants in the chatbot group. Was they report they have suspected HIV positive cases, and same number of there are also 2 in the OIC group report positive result. And for those in for the first case, and the users, when he answered the multiple choice questions, he self-report he has a positive HIV ST result. And he also uploaded a photo of his testing result. But after the scanning, we find that actually it's not a positive result. It shows a negative result. But it triggered the alarm. So the HIV self-testing chatbot immediately notify our project staff, and it also provide relevant information. And because the participant did his HIV self-testing at midnight, so the project staff, we contact the users in the next morning, and we immediately arrange confirmatory testing at collaborative community-based organization. And the users that he took the confirmatory testing was converted to HIV negative. So it is this case maybe he falsely select his testing result in the multiple choice questions. And for the second case, suspected case, the user self-reporting have a positive HIV ST result, and the photo uploaded by the the user also showed the positive result. And it triggered the alarm. So the chatbot notified the project staff immediately and provide him all relevant information. And also similarly, the project staff contacted the user in the next morning and arranged a confirmatory testing. So now the user was confirmed to be HIV positive and was linked to HIV treatment and care. Okay. So just to wrap up my presentation, so we find that, so based on the preliminary result, we find that the HIV self-testing chatbot was feasible and was acceptable to deliver real-time instruction and counseling support for the MSM HIV self-testing users. And so according to our preliminary results, so the chatbot is non-inferiority to the HIV STOIC in improving the HIV ST uptake. But more HIV self-testing users in the chatbot group received the counseling along with the HIV testing, so especially for the comprehensive counseling support. And the HIV self-testing chatbot can ensure good linkage to care among the users. So we didn't encounter difficulties in handling suspected HIV positive cases. And as compared to the human-delivered counseling support, the chatbot requires fewer resources to implement, and we believe it to be potentially sustainable. Okay, so that's the end of my presentation. Thank you very much.
Thank you very much, Dr. Wang. Very interesting intervention and very innovative. I think we have at least 2 questions on our chatbot. Yeah.
Okay. So the first question is
Yeah.
Okay. Thank you very much. Thank you for the questions. So the first question is from Venki. So the question is about, was the chatbot trained to capture emotion, mood, and nonverbal cues through the knowledge graph? So it is not. So it is not that advanced. Okay, so I think it is a basic chatbot. So it can only retrieve some keywords from the text-based communication. So it cannot capture the emotion and mood or all these sophisticated feelings. So this version of chatbot was not able to do it. But our team is also trying to use the chat. Now we are trying to explore the potential of ChatGPT. So I think with the advance in the large language model and ChatGPT, so we should be able to do it. So I think it's possible to do so in the future. But the only concern is about the accuracy. So for capturing the emotion, the mood, so that they require it has a much higher requirement about the accuracy, so than the text-based communication. Okay, so I'm not sure whether I have answered these questions. Okay, so I'll also move to the next questions. So the workflow for non-reactive should be highlighted or offer PrEP. Right. Okay. So I have to explain the situation of the PrEP in Hong Kong. So in Hong Kong, so the government did not provide free or subsidized PrEP at this stage. So all PrEP have to be use their out-of-pocket money, so which is very expensive. They can only purchase it from the private clinics or the overseas clinics. So the government is somewhat hesitant to promote the PrEP among the MSM users. So therefore, in their HIV testing guidelines, so they kind of less emphasize offering the PrEP use, okay, at this stage. So we are kind of follow the SOP of the government. So for the non-reactive results, so we do give them advice about asking them to maintain safe sex behavior, or they have to do HIV testing regularly. But we try to avoid overemphasize the PrEP because now the situation is complicated. Okay. So did any of the participants shy away from the study due to anxiety from the data privacy risk or leakage the particular interaction and human interactions? Okay. So for now, we did not find any MSM they shy away from the study, because in this study, so we work with, in fact, our team has a very good reputation among the local MSM communities. And we also work with one of the largest NGO providing HIV testing in Hong Kong. So the branding can remove some of the concerns of the potential users. So for now, I think none of the participants, they are afraid of the privacy risk of the leakage. And also, because we find that there's more users using the counseling service for the chatbot instead of humans. So I think one of the potential reason is that because if they want to do testing with the chatbot, they do not need any appointment. So they do not need to communicate with the project staff to fix a time to implement the HIV testing. They can do it anytime, any place. Okay. And so, but for the human service, so they have to WhatsApp the project staff to communicate and to discuss about the time. So that, I think that's the making appointment, these procedures that do create some sort of barriers for this HIV testing, self-testing users to receive the counseling support. And the chatbot can potentially remove that kind of barriers. And I think other studies also observe some interesting findings that the people that more trust the machine than the real humans. And so I'm not sure whether our result was in line with their findings, but it's very interesting that more people would like to interact with the chatbot instead of the human, especially for the comprehensive counseling support. Okay, so see whether there are any further questions or clarifications.
Yeah, I think it's a very promising approach to take advantage of the HIV self-testing, yet to try to overcome the potential limitations there. And I feel like that will be successful and promising interventions. I have a quick question. So based on your interviews and conversations with the users, so what is their biggest concerns or challenge or recommendations to improve this chatbot services?
I think one of the biggest concerns about the accuracy of the human machine interaction. So one of their concerns that if they raise a question and the chatbot will misunderstand their meanings, and they will give a totally irrelevant answers, and they have to go back and forth again and again. So that's one of their concerns. And I think then their expectation for the chatbot is they try to make the workflow as simple as possible. And they want to have the option of skipping certain parts. For example, they can click a button and skip some of those questions they don't want to answer, something like that. So we try to build our chatbot based on their suggestions.
Okay, it's kind of the standardized procedures versus the more personalized and tailored one. Great. All right. Do we have any other questions, comments from our audience? All right. Then thank you very much for Dr. Wang giving us such a wonderful presentation. And we are looking forward to the follow-up data and the results.
Thank you.
And due to the time conflict, I don't think our facilitator, Dr. Benki Olatosi, is still available. So that will be very nice that Dr. Wang do me a favor to introduce me as a next presenter.
It will be my privilege to introduce you. Okay. Okay.
Thank you.
So as I mentioned, it's my privilege is to introduce Dr. Qiao Shan. Okay, so Dr. Qiao is associate professor in the Department of Health Promotion, Education, and Behavior at the University of South Carolina. And she obtained her PhD degree in the Bloomberg School of Public Health at the Johns Hopkins University in 2012. And Dr. Shan has been engaged in HIV prevention and treatment studies since 2006, and with the focus on the behavior, clinical outcomes, as well as the psychosocial well-being issues, such like the disclosure, stigma, resilience, and chronic stress. And he has been working with diverse priority population, including female sex workers, men who have sex with men, children affected with HIV, and as well as the people living with HIV in China, Zambia, and the United States. And she's now expanding her research and exploring the health disparities and inequities using big data approach. So how wonderful. And Dr. Qiao has excellent ground record. So as I can see, she has secured 3 NIH grants and 2 CDC grants, and 1 NIMH contract as principal investigator. And she won the David Rothstein Award at the annual conference of American Public Health Association in 2013, the International Scholarship Award in the 20th International AIDS Conference in 2014, and the Chinese University of Hong Kong Award for Visiting Scholars in 2017. And she was also selected to receive the Breakthrough Star Award in 2020 at the Ann Johnson Institute, Faculty Fellow 2021 at USC. So now I pass the time to Dr. Qiao. Okay, so the time is yours.
Thank you very much for your introduction, Dr. Wang. So today my presentation is titled The Stigma, Mental Health, and HIV-Related Outcomes Among GBMSM in Zambia. So by GBMSM, I mean the gay and bisexual men who have sex with men. And first of all, I would like to greatly appreciate the NIH grant and also our research partners from University of Michigan, University of Zambia, and also our local partners in Zambia. And also would like to acknowledge our wonderful research team, the co-investigators and college in the USA side, in Zambia side, and also our wonderful co-authors and PhD students, the research assistants. They contribute a lot in the manuscript development. So let me briefly introduce Zambia. So Zambia is a land-located country in Southern Africa with a population of about 16.2 million. The economic in Zambia keeps growing over 2 decades thanks to its stable political environment. In 2023, the GDP per capita in Zambia is about $1,500, and the life expectancy at birth is nearly 65. However, the HIV epidemic is a big challenge for its public health. Zambia is known as one of the top 10 countries with the highest HIV prevalence rates in the world. So Zambia has the highest HIV prevalence rate among adults aged 15 and above years in sub-Saharan Africa, as nearly 11%. And by 2019, it was estimated that 1.2 million people in Zambia were living with HIV. So gay and bisexual men who have sex with men, GBMSM, is a key population for HIV prevention and treatment in Zambia. Actually, GBMSM was identified as one of the key populations since 2017 for their AIDS national strategic frame. However, we can see that the HIV prevalence rate was pretty high. So generally in the sub-Saharan African countries, the HIV prevalence rate among GBMS is about nearly 18%, compared with the 6% for the other men in general population. But in Zambia, the HIV prevalence rate among GBMSM population was as high as 33%. And also, align with the systematic review introduced by Dr. Seward Harrison, we can see that in Zambia, the mental health problems had a very high level among GBMSM compared with the general population. For example, in terms of depression and anxiety, it's like multiple times higher chance for the GBMSM suffering the depression and anxiety. And actually, that's not the individual reasons, but can attribute to the harsh social and cultural environment for GBMSM in Zambia. So in terms of the religions, almost 99% of the people in Zambia believe in Christian, so it's totally a Christian country. And according to the religion's leaders, they really viewed the homosexual as negative and Christian. In terms of the cultural context, same-sex sexual behaviors are considered as abnormal in Africa. Actually, according to Pew survey in recent year, Zambia peoples have the lowest tolerance rate for homosexuality. And in terms of their legal system, same-sex sexual behaviors are criminalized in Zambia, and that's leading to the serious violations of the basic human rights. And those are the news reports and the stories. In 2019, you can see the titles of those stories. Zambia's president says it won't promote the LGBTQ rights in exchange for foreign aids. And the gay couple in Zambia sentences to 15 years for their sexual behaviors, which was viewed as crimes against the order of nature in Zambia. So in this harsh social environment and cultural context, stigma against GBMSM is very persistent in Zambia. And here is a brief definition of stigma. Goffman, a sociologist, give the classical definition of stigma. The core of this concept was discrediting and devalued. And the stigma could manifest it in different ways, like in aspect of emotions, that could be the feelings as disgust, anger, fear, protestings, and in terms of the perceptions and attitudes, that could manifest it as stereotyping or labeling. And in terms of the behaviors, we call it discriminations. For example, the social exclusion, social distancing or isolations, and also unfair and unjust treatment in job opportunities, in school, in health treatment and care. And in terms of types of stigma, some commonly used definition of the types of stigma include perceived stigma, that's the perceptions of negative attitudes from society or community. Anticipated stigma, that means anticipations of being stigmatized by others, like family or healthcare providers or communities. And then internalized stigma, or we call self-stigma. That's personalized feelings or feel be discredited or deserving of the negative outcomes. And finally, enacted stigma, or we call it discriminations, that's the personal experiences of stigmatizing behaviors. So our project will focus on the different types of the stigma among the GBMSM. So the first aim is to identify manifestations of different types of stigma against GBMSM in clinical settings in Zambia. And the second aim is to explore the effects of stigma in clinical settings on GBMSM's mental health and HIV prevention and treatment cascade outcomes. And finally, we're trying to identify the mechanisms of these effects to inform effective strategies and interventions to reduce the stigma in clinical settings in Zambia. So our project was consisted of 3 phases in terms of the data collection and data triangulations. So phase 1, we engaged the local communities by building up the community advisory committee and conducted the policy reviews and the literature reviews to understand the big social environment for the GBMSM. And at phase 2, we completed the in-depth among GBMSMs who aged from 18 to 35, recruited from Lusaka, the capital city of Zambia. And we also interviewed 20 healthcare providers and 30 as community leaders. We finished the interviews in 2020. And in phase 3, we collected quantitative data through surveys with 206 GBMSM and 200 healthcare providers. We recruited them from the 4 different districts in Zambia. They were Kaiwi, Dola, and Livingstone. So next, I will introduce the results based on the both qualitative and quantitative studies. So here is a brief and demographics features of our GBMSM participants. So basically, they were very young. Average age was 24, and majority of the participants attended senior secondary school, and over half of them reported that they were able to work and they were seeking employment, but at that moment they were unemployed, and majority of them were single. So our first study is to examine the associations between enacted stigma, mental health outcomes, and HIV-related risk behaviors and substance use. So you can see the participants who reported a higher level of enacted stigma were more likely to report a higher level of anxiety symptoms and having probable PTSD symptoms than those who reported a lower level of enacted stigma. And also they have higher chance to have ever used tobacco and cannabis than those who reported a lower level of enacted stigma. In terms of the HIV-related sexual behaviors, so the participants with a higher level of enacted stigma reported a higher number of sexual partners in the past 3 months compared to those with lower level of enacted stigma. Yeah. And our second study report here is a qualitative study. So when we conducted the qualitative data from both GBMSM and the healthcare providers, so we find out that the communication quality between the GBMSM patients and healthcare providers was very poor. That's because of the lack of knowledge and their needs of the GBMSM. Also it's due to the lack of the GBMSM patients. They didn't have enough knowledge where to go for the resources and where to reach out to the friendly HIV or STI services for GBMSM. And those lack of communication and knowledge results in the distrust between the two parts. So the healthcare providers would not like to or not feel comfortable to serve the health to serve the GBMSM, and also the GBMSM lack of the basic trust. They just worried about the confidential and privacy issues, and they would not like to open up to the healthcare providers. So it's both sides reported it's difficult in establishing comfortable mutual trust and a working relationship. We also find out that it is notable that the healthcare providers' loyalty to the religions, to the traditional Zambia culture could be barriers for their willingness to have the open communities with the GBMSM. But their loyalty to health services oaths and the caring others values makes them willing to learn or to receive the trainings to improve their communication skills with the GBMSM. So here you can see some example citations. Like this doctor is Christian, so she shared her struggles, like because you see me, I am a Christian, I can't talk about what is biblical, and by that kind of thinking, you even hinder good service provision. And also she mentioned that the GBMSM fear that maybe the healthcare providers will report the GBMSM to the police because the same-sex activity is not allowed, and it is a 5-year sentence. So those are some of the things that they fear, much as they would want to open up, they have those fears. And also from the GBMSM side, they just express their concerns and distrust, like how trustworthy are they? I go and I get tested, you find me positive, you find me with this STI. How privately are you going to keep it? So they really worried about the privacy issues. And then the second studies, we try to examine the mechanisms between the stigma and the HIV-related behavior outcomes. So this is SEM model, and we identify that the HIV-related stigma was directly and negatively associated with physician and patient interaction quality. And this physician-patient interaction quality was directly and positively associated with HIV testing intention in next 3 months and the PrEP uptake currently. And also the interaction effect of HIV-related stigma on HIV testing intention and the PrEP uptake was tested using the Delta Z score. And since it was significant, so the results should suggest that the HIV-related stigma had a negative and significant indirect effect on HIV testing intention and the PrEP uptake through the physician-patient interaction quality. And then we also take advantage of the data collected from the healthcare providers. So I'm trying to identify if there are any contextual factors that will contribute to this bad physician and client interaction quality. So again, we conducted this mediation analysis, and we used the stigmatizing clinical settings measures. It has 7 items to assess the stigmatizing environment in the HIV clinics. For example, the numbers of observed stigmatizing and discrimination events against people living with HIV in the health facilities and the healthcare providers. They're experienced stigma from their colleagues because of providing treatment and care to the GBMSM. So we finally identified that, okay, the high-level stigmatizing clinical settings in the HIV facilities had a significant and a negative indirect effect on the physician and client interaction quality through the increased perceived stigma against people living with HIV among the healthcare providers. So next, I would like to wrap up the key findings of those studies that we use in the mixed methodology in Zambia. So number 1 is we have already seen that the enacted stigma has a negative impact on mental health, substance use disorders, and HIV-related behaviors among the GBMSM. And second is that the stigma against GBMSM and HIV can be manifested as poor interaction quality between the GBMSM clients and the healthcare providers in the clinical settings. And further, this poor interaction quality mediated the negative impacts of HIV-related stigma on HIV testing intention and PrEP uptake. And finally, the stigmatizing clinical context in the HIV clinics or the health facilities will significantly and negatively affect the interaction quality between GBMSM and the healthcare providers, which may further influence the quality of treatment and the care services provided to the GBMSM. So, what are the take-home message and what are the public health implications of those findings? So number one, again, we call for the integrated HIV prevention and care services, given the stigma, especially the enacted stigma against GBMSM in Zambia. And the prevalence of mental health problems and substance abuse disorders. So we can consider provide training of the existing healthcare providers in the HIV clinics to equip them of some basic mental health knowledge and let them know the unique needs, especially the psychosocial well-being needs among the GBMSM. And we can also enhance the tailored screening and referring systems, so help the GBMSM to access and to linkage to the mental health care in a timely way. And second, we think that the healthcare providers training for stigma reduction could focus on the improving the communication and interaction quality, because this is prominent problems in the clinical settings in Zambia right now. So we need to help the healthcare providers to improve their communication skills and also to help them to build up the positive, comfortable, and mutual trust relationship with their GBMSM clients. And finally, we would like to highlight the needs of the institutional level interventions to change the stigmatizing clinical context, because the commitment and efforts from the leadership, from the institutional level, is very critical for a successful and sustainable HIV stigma reduction interventions. When you change the clinical setting environment, and I believe that more and more healthcare providers will feel comfortable and confident to better serve their GBMSM clients. So this is my presentation, and any questions, any comments? Thank you very much. Okay, if we don't have
李小然，赶快洗澡去。
为什么要洗澡？我昨天洗了，前天洗了，前天洗了。
每天都要洗，就像每天。
你洗了吗？你还没洗呢。
我刚才都洗过了。
那是我不洗。
Sorry to interrupt. If you're not speaking, can you please mute yourself? Thank you. Go ahead, Chen.
Okay, and feel free to reach out or share your experiences in doing research or interventions in Africa. And I really appreciate your attention for this presentation. All right, so we will move on to the next presenter. I'm glad to introduce Mr. Abhishek Agarwal to give a presentation on stigma-related measurement assessment. So let me briefly introduce Mr. Abhishek Agarwal. So he's currently a PhD candidate at the Department of Health Promotion, Education, and Behavior at University of South Carolina. He has 2 years of experiences in designing and implementing mental health interventions for adolescents across different states in India. Through such experiences, he serves as international leader from India at the School Mental Health International Leadership Exchange Program. Abhishek's current research not only explores the mechanisms through which stigma influences HIV prevention behaviors, but also underscores his keen interest in intensive longitudinal data to gain deeper insights into the behavioral health dynamics. So next, let's welcome Abhishek to give his presentation on the measurement scales assessment.
Hi, thank you, Dr. Chow, for the introduction. I hope you can hear me and see the slides.
Yes.
Okay, thank you. So, just a sec. So this topic focuses upon the measurement scales assessing multifaceted stigma related to sexual and gender minorities. This is a systematic review that we conducted at the University of South Carolina in the Center for Healthcare Quality Lab. And this systematic review looks at the scales or the measurement instruments that were used to measure stigma, specifically related to the sexual and gender minorities. Just a small introduction related to sexual and gender minorities. So we all know that sexual and gender minorities are defined by their sexual orientation and their gender identities. So these includes gays, lesbians, bisexuals, and individuals with the same sex attraction or behavior, and certain gender minorities like transgender and gender non-conforming. The existing literature talks about the different adverse health outcomes that have been faced by sexual and gender minorities, specifically the high prevalence of HIV and STIs, mental health disorders, and substance abuse. Stigma is one of the critical factors because of which we witness severe health outcomes amongst the sexual and gender minorities. Stigma can be easily understood as the stereotyping or ostracizing of marginalized groups, which can also be referred to as the us versus them mentality. And stigma specifically related to the sexual and gender minority also stems from the fact that homosexuality was considered a mental disorder until 1973. And as also referring back to Dr. Chow's presentation, where we saw that stigma is still sexual and gender minorities are still considered as criminals, or same sexual activity are still considered a criminal act in certain geographical contexts or cultures. So those are the prominent reasons why stigma is so prevalent and pervasive across all spheres of life, especially for sexual and gender minorities. Due to this stigma, the SGMs, or the sexual gender minorities, face multi-level stressors. Stressors at the structural level, which refers to social marginalization, police violence, sexual abuse. It can be at the interpersonal level, referring to family rejection or partner violence, or at the individual level, where the stigma over a period of time is internalized. And such internalized stigma specifically leads to a lot of mental health issues like anxiety or self-harm. So looking at the impact of stigma, such as reduction in social support seeking, positive coping, increase in mental health issues, substance abuse, and also the structural stigma causes delayed access to health services, lower rate of HIV testing. So looking at the adverse impact of stigma related to the sexual gender minorities, it makes for a very strong case that we need to measure stigma accurately, specifically for, again, the SGMs, because the measurement of stigma needs to represent their lived experiences. And measurement of stigma is also a key component of the different intervention strategies that are implemented for SGMs, which might be related to their mental health, substance abuse, or related to HIV prevention behaviors. So for all these interventions, measurement of stigma becomes a very important factor. So therefore, we need to have tools or instruments that accurately represent the lived experiences of SGMs. Currently, in the literature, there are very limited instruments to assess stigma among SGM, and also the instruments that exist, the validity and the robustness of these instruments is a concern. There have been previous review studies that have looked at the different stigma measures or instruments that exist. But there are certain limitations for the previous reviews that exist. So the first one being that the existing reviews have only focused on specific SGM groups or regions. These reviews did not include all types of SGM groups or all types of regions. Secondly, they were limited to certain stigma types. So when we talk about stigma, there are various types of stigma: internalized stigma, enacted stigma, perceived stigma. So the existing systematic reviews focused on one or two types of stigmas, but did not adopt a very comprehensive approach towards all the stigma types, or the reviews did not very comprehensively criticized or critically evaluated the psychometric properties of the existing stigma instruments that exist. So our study wants to adopt a more comprehensive approach. We want to include all type of stigmas, such as internalized, perceived, enacted, etc. And we want to include all types of SGM groups, such as gays, bisexuals, lesbians. And at the same time, we also want to have a very comprehensive approach for evaluating the psychometric properties of the instruments. And the goal of the study is to recommend measurement instruments for different types of stigmas for the SGMs. Now coming to the methodology that we adopted. So our systematic review followed the PRISMA guidelines for the review. And we looked at 4 databases: Medline, PsycInfo, Senhal, and Web of Science. And this database search was conducted in September 2022. On the right-hand side, you can look at the search strategies that we used for the different databases. We actually organized the keywords into 3 different categories, including gender identities, stigma, and the third one was related to measure, because we specifically wanted studies that assessed or evaluated psychometric properties of stigma instruments. So, and as you can see, we used the logical operators or and to differentiate among different keyword categories. This is the flowchart for the studies that we screened. So as you can see, we in total extracted 2,031 studies from all the 4 databases, and then duplicates were removed. And in total, ultimately, we selected 19 studies after the screening process of title and abstract screening, followed by full text screening. You can see that the inclusion criteria were specifically English articles that were published from 2010 onwards until that date. And we wanted articles that assessed at least one psychometric property of the stigma instrument that they were talking about. The exclusion criteria were studies in which the research objective was not related to psychometric properties. For example, any form of empirical study where a stigma instrument was used, but the psychometric properties of that instrument were not assessed. That study was excluded. We also excluded the studies that only collected qualitative data, and also the studies that did not exclusively focus on SGM. So we wanted the studies to have at least one SGM group in their population. This is the data extraction process that we followed. So first, we looked at the study features. The study features included the measurement instrument, definitely, the type of stigma that the measurement instrument assessed, the description of the measurement instrument, the population of the study, the age of the participants, sample size, and country. So this is the table 1 in our study. As you can see, the description of the measurement instrument includes the different factors that were a part of that instrument and the number of items within each factor. Also, we categorized based on different stigma types. In coming slides, I will tell you about all the stigma types that we collected, that we defined. And the second table focused on the psychometric properties of the instruments. As you can see, so these are the 6 psychometric properties on which we extracted the data. The first one being internal consistency, which can also be referred to as reliability. So for internal consistency, our focus was to look at Cronbach's alpha for not only the entire scale, as you can see over here, but also the Cronbach's alpha for each factor within an instrument. The second is the retest reliability, which most of us will understand whether the same instrument was measured multiple times with the same participants over a period of time. And we looked at the ICCs or the correlation amongst the scores on that same instrument over a period of time, which is referred to as the retest reliability. Third was the content validity. Fourth is the structural validity. Over here, structural validity basically refers to whether factor analysis was conducted, exploratory factor analysis and confirmatory factor analysis was conducted to identify the number of factors within a particular instrument. And then fifth is the criterion validity. So criterion validity can be concurrent validity or predictive validity. So this primarily looked at whether there is a gold standard against which the current instrument is being correlated with. So that's criterion validity. And then construct validity, which basically refers to the correlation of the current scale with other instruments or other scales which have similar or completely opposite theoretical meaning or understanding. So this is how we extracted the psychometric properties. So we had a different table in which I explain how each and every metric was evaluated or reported over here. Then the third table was the methodological quality of psychometric properties. So there is a Kosmin checklist in which it is defined how the internal consistency should be measured or how retest reliability should be measured. So that Kosmin checklist gives description about the different types of methodological qualities that should be followed or should be adhered to in order to measure internal consistency or retest reliability or other psychometric properties. So we had 2 coders who actually evaluated the methodological quality of each psychometric instrument, and then we came up with a total score for each psychometric properties methodological quality. So you can see the scores over here. It's an example. This is how our final table looked like, which brought together all the information. So this table, this evaluation table basically includes the information on psychometric properties that you can see here and also the information on methodological quality. So the header PQ refers to the psychometric quality and MQ refers to the methodological quality. So you can see that for each scale, we quantified the psychometric quality and the methodological quality. If the psychometric quality was not reported, then we had not applicable for methodological quality. And then for each scale and for each psychometric property, we came up with a final score based on the the different scores that they attained on psychometrics and methodology. So you can see this was our scoring metric over here on the right-hand side. So if a particular scale or stigma instrument had a positive rating on psychometric quality and had a strong rating on methodological quality, then that scale was assigned a score of 3. Similarly, if that scale had a positive rating on psychometrics and a moderate rating on methodological quality, that scale was assigned 2. And in a similar fashion, we had scoring for all different permutation combinations that existed. So over here, minus and strong for internal consistency would give a score of -1. So this would be -1. And then similarly, adding on for all the psychometric properties, we had a final score. And also, as I mentioned before, the instruments were divided into different types of stigma. So the first one was combined stigma, which had 5 instruments. The second one was enacted stigma, which had 2 instruments. The third one was internalized stigma, which had 5. And then we had intersectional stigma, which had 2, and perceived stigma, which had 3 instruments. So we divided all the studies and the instruments within those studies into different stigma types for reporting purposes. This also gave us an idea about how many instruments exist for different types of stigma, which can guide the future studies about the stigmas that they need to focus upon for developing more instruments. And this is the table that you can see on the left-hand side that was used to actually give the ratings on psychometric properties. So for example, for internal consistency, if the Cronbach's alpha was more than 0.7, then it was given a positive rating. And if any one factor within a scale had a Cronbach's alpha of less than 0.7, then that scale had a negative rating. Similarly, we had this across all the psychometric properties. And this was the table that was used as a reference to give negative and positive ratings over here. So this was a multi-stage, multi-level process that we followed for multiple tables. The results of the studies are as follows. So we reported 17 instruments. So even though we had 19 studies, there were a couple of studies that talked about the same instrument, maybe different psychometric properties. So in total, we had 17 instruments. These instruments assess different types of stigmas: combined stigma, enacted stigma, internalized stigma, intersectional, and perceived stigma. So as you can see, for combined stigma over here basically meant if a particular instrument is measuring more than one stigma, then that was included in combined stigma. And enacted stigma is an internalized stigma, and perceived stigma are pretty common. But intersectional stigma over here refers to whether there was an instrument that looked at stigma for multiple identities of sexual and gender minorities. And this one was perhaps the most interesting one, which we also discussed in our discussion section. And there were different populations that were studied. There were MSM, GBM, SMW, transgender, and even university students. Over here, university students basically refer to that there was an instrument that assessed the level of stigma amongst the university students against the sexual and gender minorities. This is the age distribution that you can see. Majority of the participants were young. This is the sample size that we found across different studies, and the geographical distribution. Majority of the countries where the instruments were tested were high-income countries. Very few studies or instruments were developed and tested in low or middle-income countries. So for each stigma type, you can see that for combined stigma instruments, we had in total 5 instruments. These are their names. All these instruments reported internal consistency and content validity. Majority reported structural validity and construct validity. So these were the 2 instruments, MSS and SSS, which scored the highest for combined stigma. And it was generally observed that internal consistency and content validity was reported across most of the instruments, but criterion validity and retest reliability were 2 psychometric properties that were rarely reported by any study. So in one of the future directions is also to have a focus on measuring the criterion validity and test-retest reliability. So for enacted stigma, there were only two instruments. Both of them reported internal consistency, content validity, structural validity, and construct validity. And this instrument over here had the highest score or the best psychometric properties amongst the two instruments. For internalized stigma, we had 5 instruments and all reported internal consistency, content validity, and construct validity. And SOCS was the most robust instrument. Intersectional stigma had only 2 instruments, IS and IRSS, and both reported internal consistency, content validity, and construct validity. And IRSS had superior psychometric properties compared to IS. And perceived stigma instruments, there were 3 instruments, all reported internal consistency and content validity, and GCSS had the best properties. So in our paper, for each stigma type, we report the best instrument based on the psychometric properties and the scores that they get. And at the same time, we also report the different psychometric properties that were not reported and the need for future testing. So these are some of the results related to the different stigma types and their instruments. So you can see that SGM men had majority of the instruments targeted SGM men, whereas very few instruments targeted SGM women. So 11 out of 15 instruments targeted SGM men, whereas only 6 out of 15 instruments targeted SGM women. See, and also within SGM men, we can look at the gay men, men who have sex with men, and bisexual men. So we disaggregated the instruments based on the different sexual and gender minority groups in order to see look at the groups that do not have sufficient instruments. So generally, SGM women did not have sufficient instruments. And for each sexual and gender minority, we had the best instrument based on the scores on their psychometric properties. And these are the instruments on other specific groups. So you can look at transgender women only had 1 instrument, sexual minority women only had 1 instrument, and transgender individuals only had 1 instrument. So this helps us understand the populations we need to target. So generally, enacted stigma, intersectional stigma, and perceived stigma had very few instruments. And there were only 2 instruments overall that reported all the psychometric properties. Internal consistency and content validity was reported for all instruments, and construct and structure validity was also reported for majority of the instruments. However, test-retest reliability and criterion validity was reported only for very few instruments, that is 5. So for each type of stigma, we had 1 best instrument, and for combined stigma, we had 2, which there was a tie based on the scores. And moving forward, we found that intersectionality approach was an interesting and more meaningful way forward in development of stigma instruments, because each sexual and gender minority had an intersection of various identities. Since, like, for example, a Black gay man may face racism because of his race, homophobia because of his sexual orientation, and then a unique combination of these stigmas due to the intersection of his Black and gay identities. Therefore, we urge the future studies to adopt a more intersectional approach in development and assessment of stigma among the sexual and gender minorities because of intersectionality of their various and multiple identities. Generally, we found that these are the challenges that were faced by the existing studies. So many studies included instruments that were assessed that measured stigma amongst more than 1 SGM group, but we found that there was no clear theoretical foundation for grouping SGMs, and that's why we urge the future studies to adopt more theoretical approach in deciding the different sexual and gender minorities amongst whom they want to assess stigma. And the studies had a lower generalizability because they only looked at younger populations and also only higher income countries. There was low level of evidence, which basically meant that participants that For each instrument, there was only one study that was reported. However, it is preferable that each instrument has multiple studies in which that instrument has been tested with different populations in different contexts. And the last one being methodological quality. We followed the Cosman checklist for assessment of methodology, but this checklist has subjective understanding of the different criterias. So we urge the new studies to adopt more robust measures. And also, uh, it was observed that some instruments may report internal consistency or structural validity. However, structural validity should be performed before reporting internal consistency. So we also talk about that that factor analysis should be conducted before performance of internal consistency or Cronbach's alpha. There were certain limitations of our study. For example, intercoder reliability was not reported. Certain databases like Google Scholar or unpublished work or conference articles were not included. And also, we did not include cross-cultural validation or measurement invariance as a part of our study. Fourth, methodological quality used Cosman checklist, which can be subjective due to the nature of its items and response scales. And also the scoring system that I showed you before, in which we had given the weights of 3, 2, 1, or -1, -3, or -2. So those can be different for different contexts based on the goal of the study. So that cannot be completely homogeneous. Thank you.
Thank you very much, Abhishek. I think that's a nice study to assess the quality of the stigma measurement, especially the stigma against the SGM group. Let's see if we have any questions and comments from our audience. Okay, I understand that for some of our audience, it is late evening. So like just to speed it up, move to the next presentation and also the final presentation of our session. So it should be given by Dr. Yu Liu. But actually, unfortunately, Dr. Liu is not able to join us online because yesterday he sent me a message saying he was stuck in the airport and was not able to go back to Buffalo. But he's so kindly to record his presentation at the airport. So today we should be able to share the pre-recorded video for his presentation. So let me share the I'm not sure. Nadja, can you share the folder and so I can go ahead to briefly introduce Dr. Yu Liu. Okay, I will first introduce Dr. Liu. Dr. Liu is assistant professor in the public health science at the University of Rochester. He completed his pre- and postdoctoral training at Vanderbilt University Medical Center with a background in HIV epidemiology, social behavior science, and global health. He is dedicated to addressing inequity in access to and utilization of healthcare among populations facing various social environmental challenges. Specifically, his research involves collaborating with various academic institutes and community-based partners to design culturally appropriate strategies to address psychosocial issues such as social stigma, mental health, substance abuse, and social economic adversities. He has served as PI, MPI, co-I of multiple institutional and NIH-funded HIV prevention studies in China, in Zambia, Senegal, Uganda, and the United States. His recent research includes 2 community-based studies in Buffalo, New York, and Nashville, Tennessee, to study resilience factors to counter sexual minority stressors, mental health burdens, and substance abuse among young MSM at high risk for HIV. He also led a social media mining study using big data from Twitter to explore PrEP-related communication and surveillance priorities among MSM in need of targeted HIV prevention services. Notably, he serves as the research advisor for 2 community-based LGBTQ HIV prevention centers, with focusing on improving diversity and inclusion in research. He has an unparalleled passion for contributing to cultivating organic, unbiased, and sustainable environments across various services, educational, and research settings. So next, I would like to share the video.
Good morning, everyone. My name is Yu Liu. I'm an assistant professor of epidemiology at the University of Rochester.
Can you see the screen and hear the presentation? No?
You can only see the folder that is open.
Okay, I will try it again. Sorry about this technical issues. Okay, here we go.
Rochester Medical Center. I'm sorry I cannot be with you virtually today because I was stuck in the airport and my flight was canceled, got scheduled to another flight that happened to conflict with our online section. But today I want to present you some research that I've been engaged in the past few years, and I'm hoping this will be some interesting topics to you. So basically, in the United States, the male-to-male sexual contact account for the vast majority of new infections in the States. As you can see here, the male-to-male sexual contact, like HIV infections among men who have sex with men, account for approximately 66% of new infections. As we all know that there are 2 primary HIV prevention tools that we can use to prevent HIV transmission among high-risk populations. The first is the treatment as prevention, and the other is through the implementation of pre-exposure prophylaxis. So, but either way, the most important step or the gateway of either the prevention with positive or the prevention with negative always begin with HIV testing. As you can see here, HIV testing is very important to really test and capture those who are HIV positive and to diagnose those who are HIV negative, but they are at high risk of HIV, and then put them on PrEP to curtail the transmission of HIV among men who have sex with men. So this is a report that we published previously, kind of showcase the HIV testing prevalence among Black men who have sex with men. As you can see here, the prevalence was pretty high among those who have reported every testing for HIV, but the prevalence kind of begin to decrease, moving from the past 24-month testing to the frequent HIV testing. Means that people who test for at least once every 3 to 6 months. And this is another systematic review that we published previously, showing that there's still a very huge challenge to implement the PrEP among Black men who have sex with men in the United States. As you can see here, we through a bunch of studies, like 60 studies, that's being done among the Black men MSM in the United States. Actually, the awareness and the willingness was pretty, compared to the uptake was pretty high. It's around like 50 to 60% of the survey participants report that they're aware of PrEP or willing to use PrEP. But when it comes to actual PrEP uptake, it kind of decreased to like 16% of the pool participants who report ever using PrEP. So we did another 2 subsequent systematic reviews and tried to summarize existing evidence in terms of interventions that can help promote HIV testing and PrEP use among men who have sex with men. And so basically we, based on these 2 very important reviews, that we find some very important findings. The first of it is the importance of a community participatory research. So we always need to collaborate with the local communities because they really understand the needs of the local MSM or the sexual and gender minority men, their needs, their HIV prevention needs. So these will really like help us to prioritize the research or the prevention effort with this population. And the multi-level intervention is very important. So for things to work, we cannot just focus on one level, like the individual level, or only focus on community level. That's not sufficient. We need to leverage resources from multi-level, like multiple social ecological levels, and combine or integrate these efforts and strategies to design useful prevention strategies for men who have sex with men in the United States. And another key point is implementation science. So we need to really understand what are the most important strategies that to tailor the existing or proven strategies to really make it work among the new local communities. Another key finding is the social media and technology-based and the use of big data science techniques to leverage these novel strategies to understand the prevention needs and probably to use these technologies to help us to monitor or conduct surveillance of the, for example, HIV prevention behaviors or risky sexual behaviors and all these kind of things that are very important for us to design relevant interventions. But last but not least is that we need to understand like nuanced differences in social media, in social, mental, and behavioral factors to reduce health disparities among MSM of different races and ethnicities. So this is a very, very essential step to help us to address the health disparities or HIV prevention disparities among various subgroups of MSM in the United States. So we implemented a study back in 2019 and 20. So the study was named the HIV Testing Self-Efficacy Study, which was funded by the Center for AIDS Research at University of Rochester. And it's a combined finding by the CFAR and the School of Medicine and School of Nursing. It's like a joint award for us to implement a pilot study to understand or explore the multi-level factors and the intervention opportunities for improving HIV testing and PrEP uptake among MSM in 2 high-risk communities in Nashville and Buffalo. So this study involved collaborators from the University of Rochester, from Nashville Cares and Evergreen Health, which are 2 LGBTQ-friendly, community-based HIV provision service centers. And so for this study, we implemented the multiple convenience sampling strategies For example, we social media post push-ups, we distribute flyers to the sexual minority men frequenting venues, and we also use the peer referral methods. And for the men who are eligible to be included, they need to be cisgender men older than 18 years old and by the time of the study participation, and they have to report having at least one encounter of sex with the other men in the past 12 months. They have to be able to understand and speak English, and they have to be HIV negative. So we distribute a cross-sectional survey using RedCap to survey a variety of data, like psychosocial determinants, HIV prevention outcomes, demographics, and trying to understand what factors are driving the use or not using PrEP or their HIV testing patterns among the men in the two communities. So by 2023, this month, we have published 9 papers using the data from this pilot studies. So we focus on a variety of topics or domains. We focus on determinants of mental health. We explore patterns of drug abuse. We understand factors associated with their quality of life. We understand their bisexual behaviors and their sexual patterns and how that may drive the HIV epidemics or dynamics within the local communities. But for this presentation, because the time is limited, I'll just focus on one piece of research that we published previously using this data. So back in 2021 or 2020, we published a study in trying to really characterize the racial differences of mental health burdens and the psychosocial determinants and their impact on HIV prevention outcomes. Previous studies among MSM in the United States, and so a vast majority of research have been done to really understand these factors within a certain specific demographic subgroups, like for among white MSM or Black MSM or Hispanic MSM, but few studies have ever done to really compare the HIV prevention behaviors, see if they varies, and if yes, like what are the psychosocial determinants driving the racial differences. So that's the motivation that we leverage the study and use part of the data to answer these specific research questions. So here are some key measurements related to the key exposures. So basically, we measure some mental health burdens. We measured anxiety, we measured depression, and perceived stress. So for anxiety, we use the Generalized Anxiety Disorder Assessment, G87, and depression, we use PHQ-9, and the perceived stress, we used the 10 out of 10 perceived stress scale. So basically for these measurements, we operationalize them as both continuous variable and use the proven analytical cutoff points to categorize them into like a minimal, mild, moderate, or severe conditions for each type of mental health burdens. And we also collect data on some other variables, like for each HIV prevention outcomes. We ascertain their alcohol use before sex, if they use drug before sex, and their continence anal sex patterns, and their HIV testing frequency in the past 3, 6, or 12 months, and their PrEP continuum outcomes like PrEP awareness, willingness, and ever use PrEP. And for some key psychosocial determinants, we ascertain some key factors such as their housing stability, their food insecurity, HIV stigma, homophobia, social support, loneliness, and some resilience outcomes using various scales. So here are some key outcomes associated with the present study. So basically, first we kind of run the correlation analysis by different subgroups and trying to see how different mental health burdens may correlate with each other. So basically, we found that young Black MSM reported significantly higher anxiety and depressive symptoms, but they kind of reported lower perceived stress when compared to their white counterpart. And for both Black and white MSM, anxiety was highly correlated with depression. And for this table, we kind of explore the psychosocial determinants, for example, housing, food insecurity, stigma, hormone negativity, social support, loneliness, and resilience, and see their associations or relationship with different type of mental health burdens by racial subgroups. As you can see here, like there's some pretty clear pattern kind of diverge between Black and white MSM. For Black MSM, some key psychosocial determinants such as the housing, stability, food insecurity, and these items are highly correlated with all mental health burdens. But these results is not significant among white MSM. Same thing for the internalized hormone negativity. And so these psychosocial determinants was highly associated with anxiety, depression, and perceived stress among Black MSM, but the association was weak and is not significant among white MSM. There are some other protective psychosocial determinants, such as the perceived social support and the resilience. Although these two factors are both significantly associated with reduced mental health burdens like anxiety, depression, and perceived stress among both Black and white MSM. But as we can see here, emphasis was much stronger among white MSM as that compared to what we found for Black MSM. So trying to summarize that big table into some take-home message here. So for young Black MSM, those with moderate or high anxiety symptoms or depression, they were more likely to use the drug or alcohol before sex. And actually, this slide is trying to summarize another table that to explore the psychosocial determinants with the HIV prevention outcomes. And for young Black MSM with moderate or high versus low stress, they were more likely to engage in some risky sexual behaviors, such as the condomless anal sex. In the meantime, they were less likely to test for HIV or they're less likely to be willing to use PrEP or ever use PrEP. And for young white MSM, and when we try to compare young white MSM with these kind of mental health burdens to those without or have a lower level of anxiety symptoms, we found that those with moderate or high anxiety symptoms, they were more likely to engage in condomless anal sex, but they're less likely to test for HIV in the past 3 months. Here are some implications from this research. So first, we argue that the research really need to differentiate between anxiety, depression, and stress, and maybe other types of mental health burdens, because these type of mental health burdens, they are very different from each other. So they deserve to be examined individually and trying to see their distinctive correlations with each type of HIV prevention outcome. So sometimes it's not the best practice. We kind of just use one variables or measurements, try to lump together all the mental health burdens and try to examine their, as an entire group to see their entire or overall associations with any specific HIV prevention outcome, because that won't help us to really understand, what will be the best prevention strategies to tackle each. And the studies are really needed to better understand the longitudinal patterns, sources, and the multi-level mechanism of these mental health burdens. So, because obviously these studies, they're just cross-sectional studies. We don't quite know, and there's a shortage of research really trying to elucidate, see if each type of mental health burdens like anxiety, depression, and stress, like how they change over time, and what are the causes that make them change over time, and how does that may be associated with HIV prevention outcomes like PrEP abuse, HIV testing, uptake, and other risky sexual behaviors. And so based on the table that we found that some resilience factors like social support and these are factors that can really help reduce the mental health burdens and boost up some prevention uptake. So we argue that the resilient-based interventions for different type of MSM or the MSM of different backgrounds should really be strengthened, and qualitative research needs to be done to understand what are the specific resilient sources that can be leveraged to counter, the adverse psychosocial determinants, like hormone negativity and stigma, and other adverse situations as a way to really help enhance the HIV testing outcomes and PrEP uptake. And it's definitely very important to incorporate mental health counseling into the day-to-day HIV prevention services. Just want to remind everyone that this study was done it was collaborated with 2 communities, and all the MSM populations were sampled from the local communities. And we found that this type of mental health burden was really elevated and this highly impacting HIV prevention outcomes. So if we really want to improve HIV prevention outcomes among MSM, we need to understand their mental health conditions and trying to develop strategies to tackle certain type of mental health issues before we can really address the relevant HIV prevention outcomes. So here's another study that just tried to briefly talk it over with you. We kind of use the same data from the study, and we explore the psychosocial vulnerability and link to the poppers used among MSM in the 2 communities. So based on our survey, the popper use prevalence was very high. We found that 31% of the survey participants reported ever using poppers in the past 12 months. It's only lower than the marijuana use in the past 12 months. So we kind of compare trying to ascertain the demographic and the psychosocial factors among popper using young white MSM and young Black MSM, and trying to understand like what factors are associated with poppers use among these 2 subgroups. So in short, for popper using young white MSM, they were more likely to be older. They're more likely to use social media to look for sexual partners, and in the young white MSM who report poppers use, in the meantime, they report a higher level of depression, anxiety, and loneliness. But quite differently among popper using young Black MSM, so the driving psychosocial or demographic factors is more about the adverse social environmental factors. For example, those who tend to use poppers among the Black subgroups, they are more likely to report higher level of food insecurity, report higher level of HIV stigma, and report higher level of internalized hormone negativity. So here, I just want to show you how we analyze the popper use and with different type of risky sexual behaviors in table 2 and table 3. We do the race and poppers use stratified multivariable analysis of the association of HIV testing and PrEP-related outcomes. But when I summarize the outcomes from these two big tables, here are the take-home messages. So compared to the non-poppers using MSM, those who use poppers, they show an overall higher prevalence across all assessed risky behaviors, including alcohol, drug use before sex, condomless, insertive and receptive anal sex, and group sex. And for the young YMSM, the popper users, they were more likely to engage in all risky sexual behaviors. And for poppers using young black MSM and young YMSM, they were more likely to ever test for HIV during their lifetime and in the past 12 months. In the meantime, they were more likely to ever use PrEP. And however, for young black MSM who use poppers, they were less likely to engage in HIV prevention behaviors when compared to young black MSM. So some implications from this study, future HIV counseling and services should definitely include a brief screening of recent popper use because it's so high, the prevalence is so high, and it's gaining a lot of popularity among the MSM subgroups in the United States. And definitely the use of the popper using is driving some risky sexual behaviors and mental health issues. So resolving increasing popper use prevalence or trends definitely a very important research topics when it comes to HIV prevention among young MSM in the United States. So we definitely need to focus on enhancing safer sex counseling and reduce mental health burdens for young YMSM who use poppers. But for the young black MSM, we need to focus on reduce hormone negativity and HIV stigma and try to provide support for their housing and food, which could be viable solutions to reduce their predisposition to use drugs. Definitely more nuanced work should be done to understand the behavioral and psychosocial mechanism of popper use among MSM of different demographic subgroups. One thing I need to highlight is that, or emphasize is that the results definitely not generalizable to other settings. These studies were done in two local communities in Buffalo and Nashville, but really show the good way to, when you work with the local populations, we need to design specific studies to understand their needs, their HIV risk patterns, and the specific psychosocial determinants driving their substance use, mental health burdens, and HIV prevention uptake. So in this way, we can design or prioritize resources to design targeted intervention to address the HIV prevention needs among MSM in a specific community. Thank you very much.
All right. That's all presentation for today's sessions. And for people have questions about Dr. Yu Liu's studies, and he encouraged you to reach out him by emails. And I will post his email address here. And also feel free to post your questions about Dr. Liu's studies here on the chatboard. And as an organizer of these sessions, I greatly appreciate your support and attention, and also your interest in the mental health and behavioral health among LGBTQ group in the context of HIV. So actually, The presented studies, including empirical studies, which review design and evaluation of interventions, and also the measurement psychometric assessment. So I feel like I have learned a lot from those multiple types of studies in different subgroups in the different global settings, and really hope you can find some interesting things from the talks that to inform your future research or practice. So feel free to reach out to us and here I would like to share my several key points for the take-home messages. So number one, I would like to highlight the complicated and comprehensive interplays between the mental health and HIV-related behaviors and HIV prevention and treatment outcomes. So we can see many of the studies highlights how the mental health burdens will be associated with HIV-related risk behaviors, and also the HIV prevention and treatment outcomes, such as PrEP uptake and the medicine adherence of the PrEP. And also, I feel like in our discussions, we're trying to suggest like maybe another direction could also work, like how behaviors or utilization of the HIV prevention and care services may affect the mental health and the psychosocial well-beings. And also, I think it's notable to see the structural level factors such as race and ethnicity, and the stability of the housing and food and other social determinants of health factors have significantly affected the mental health outcomes, and also the mediators for the HIV prevention and the treatment outcomes. So I think the number one is we definitely need the integrated and multi-level interventions to improve the psychosocial well-being and also the HIV prevention and treatment outcomes. So the LGBTQ populations, they're not just need to like the survival, but just not just survival, but also thrive. So we definitely need the interventions to improve their mental health and quality of life. And second, I'm glad to see the innovations in the intervention approach. Like in Dr. Wang's chatbot-based intervention, we see how we can leverage the power of the new technologies in changing people's behaviors. And also, finally, I would like to highlight the reflections of our own research as the Abhishek's presentation on the stigma-related measurements. So many times we really need the reflection and improvement for our measurement, for our assessment tools, so we can reduce the potential biases in our studies, and we can develop the more reliable study tools and also the research strategies to improve our knowledge and inform the interventions in the real world. So here are some kind of the wrap up of our sessions. And thank you very much again for staying with us in this incentives workshop. And I greatly appreciate your time. And since our audience from the global, and I wish you have a good day or good night. Thank you very much for your time.